All right, everyone, welcome to Focal Points by the McCullough Foundation. I'm Mila Radetich, and today we're going to be interviewing Jim Langstaff on his new book about COVID. Now, Jim, do you believe you could introduce yourself, talk a bit more about your background, and what is the title of your book? What is it about?
Yes, thank you, Professor. First of all, thank you very much for the opportunity to speak to you and to the foundation. So my book is COVID-19, Success or Red Card, and it's available as of today on Amazon. And my background is I took a science degree with a focus in cardiovascular physiology, followed by a master's in public health. And then I've worked for several decades, mainly in research projects in hospitals and healthcare, and some projects outside of healthcare as well.
Wow, so not only did you study this, but you ended up writing a book on it. You must have some very valuable insight on your analysis of what was going on during this pandemic. Do you believe you could tell me, when did you first realize something did not add up, and what made you interested in the pandemic?
Right. So it was about February of 2020 when I became aware of the pandemic, and that's probably similar for most people. And then very early on, there were quite a few signals that didn't seem to make sense. So, for example, there were 2 military ships and 1 passenger cruise line where there had been outbreaks. And there was also some very good work done by Professor Bhattacharya at Stanford. And they both showed that up to 50% of the people who tested positive for COVID had no symptoms, didn't get the disease, and likely didn't transmit it. So what that meant was that the way the calculations were being presented to the world of a possible 3% death rate really were inaccurate. So that was the first thing. And this sort of went on with the messaging that we were hearing that, there's no one is safe. Well, that obviously was false because it was mainly known that it was a serious problem for elderly people, mainly. And so that was, and also there was, messaging that there's no treatment. And we know that there's always treatment. And in this case, there happened to be really good treatment. I mean, the medical industry identified 2 really good drugs early, hydroxychloroquine and ivermectin. And not only did they identify them, they showed that they had success, particularly hydroxychloroquine if given early. And the other thing is that medical science knew they had a pretty good idea of how and why they were working. So this all added up to contributed to the narrative, which to me really didn't make sense.
If early treatment was possible with the drugs that you mentioned, why do you think the medical industry shut those down? It shunned them. Physicians were not encouraged to prescribe them, although it was known that you could treat COVID with these.
Right. So that is one of the early big failings for sure of the response. And I think there was a group that was extremely enthusiastic about the vaccine, about that solving problems. And I was of the school, and I think many people are of this thinking, and that is that during a respiratory problem or in a respiratory problem, the vaccines are helpful, but it's not expected that they're going to do all the lifting on their own. And then we sort of learned a little more as to what the thinking was. It wasn't only that they were relying on the vaccine. They had a new technology, not brand new, but certainly one that had never been put to test with as a vaccine. And there was a lot of energy behind the scenes, maybe above the water too, about how this new technology was going, mRNA was going to revolutionize how we deal with things. And even if that were true, which it turned out to be not true, but even if it was true, no reason to wait 6, 8 months and do nothing. I mean, you have to do many things in a pandemic response. And the overemphasis on the vaccine, I think, was a problem, even if it had turned out to have been the best vaccine ever developed.
If the vaccine was being posed as being the cure for COVID and long COVID, what do you think the correct or better response would have been?
Right. So, I think you want to identify quickly the epidemiology. And there was good evidence that some of that was being done, but then you want to tailor your response based on what you're finding. So in this case, because it was something that clearly was affecting older people and people with pre-existing conditions, that really, and that the age groups and that were younger really didn't have a serious problem. There should have been a lot more targeting to that. If you're going to, first of all, not everybody agrees with me on this, but I think vaccines are helpful, particularly, or they can even be used during a pandemic, because what they're doing, if they're good, they're helping because they're helping to push the virus towards pussycat. And you want to push the virus to evolve and to mute, and it will always do that. We know that throughout history, mankind would have been eliminated thousands of years ago if this wasn't true. So what happens is that the virus is trying to avoid the natural immunity of the body, and so after 2 or 3 years, generally it goes to pussycat, but you can help it. And so you can help to push it to pussycat by, because if you have a good vaccine, it does create antibodies, and that helps to, push it along. I think if you're going to, but that's only part of it. But if you're going to put hopes on something that's never, remotely been tested, then they should have insisted that that there's also a ground-up bug alternative vaccine developed. And also early on, I think there should have been the insistence that the vaccines not only target the spike protein, which turned out to be a big mistake, but that they target they make other parts of the virus, so that you're not putting everything on something that turned out to be the most toxic part of the virus. So that's sort of a general, answer.
So you talk about all of this, including the development of vaccines, in your book. Is that correct?
Yes, I do go through early, there's 2 chapters, actually 3 chapters. The first one talks about germs and germ theory, and then I talk about, vaccines over the years. And I talk a bit about the pharmaceutical industry. And, I try to be favorable. But then at that point, I really get into the analysis of this problem, COVID-19. And very quickly, it becomes quite negative in terms of what was done, how it was done, why it was done.
Do you could tell me in layman about what you mean by versus the mRNA technology of new ones?
Sorry, you sort of faded in and out. Are you asking me about the mRNA technology?
Yes, I am, and how that compares to the ground up bug
Right, right,
vaccines,
right,
or vaccines of the past.
right. So ground up, so this mRNA sounded interesting if they had have been able to fix some of the design problems because where it had been tried up to now, limited tries, it hadn't been successful. So the big problems with the mRNA are that you're you don't really know where it's being made, and you don't know how much is being made, and you don't know for how long it's being made. So, and that's, that goes into the design really of the mRNA because you put it into an envelope, and what that does is it gives the mRNA or the uh, what you put into the body, it gives it skates. So that lipid nanoparticle gives it skates, and it tends to go all over the body and quickly. And the big problem with that is that then you're making your spike protein in different tissues of the body, causing your inflammation there. And that's not what was intended and is very contraindicated. So that's one problem. And I think another big problem with the mRNA is in order to make it work, they had to make it more stable, so it can get to the ribosome. And the problem with that is that you're going to get your mRNA hanging on longer than you want because in the natural, uh, way in which mRNA makes proteins, it degrades very quickly. So you've got some design problems, and they did not overcome them. And so as soon as that became clear, it should have been pulled. Whereas the ground up bug has been around for 100 years. And the big advantage of it is that you're putting in the antigen, so you know how much you're putting in, and it doesn't it's not wrapped in something that's going to easily make it go all over the body. So more of it is contained within the muscle. That's where your immune reaction takes place. So you're not getting into the genetic vaccine piece. You're just doing a traditional vaccine, which tried and tested, uh, works really well for serious systemic viruses that we know in the past. Also helps to reduce serious illness with some respiratory problems. And as I said, it's because it's helps to make antibodies in the blood, and it helps to push the virus towards a less lethal outcome strain, which it would be doing anyways, but you're pushing it in that direction, which is a good thing because you want it to get it to a weaker strain kind of as fast as possible. So the new technology, maybe one day it will turn out to be the most amazing technology ever, but at the moment it has design problems that we're simply not overcome. And we're not even getting into the other pieces, the adverse events and using the spike protein as, that part. But just the actual, technology itself, it's not, it was not ready.
Why do you think they chose the mRNA vaccine technology over what we had traditionally done in the past with vaccines?
Right. I think there was a group of people who were very enthusiastic, and I think that some of it is human nature. Uh, you hang on to your losers. You don't want to admit defeat. you're stubborn, you think there's a way to have a tremendous success, you believe in it, and so you're blind to the fact that it's not quite working. And that's where you hope that people involved do run into that problem infrequently, but they will do it. It is human nature to do that. So that's why you need regulatory agencies, and you need a neutral group in addition to that. That in this case, because it's a a world pandemic, you would really need a neutral group as well, with direct analysis and feedback to top people, including the president. In terms of so I think they got enthusiastic, and then they tried to make it work by giving boosters. And unfortunately, the thinking may have been, if we just produce so many of these antibodies, that it will blast the virus. But that unfortunately goes against some schools of thinking that I subscribe to, and that's that the antibody response to the antigen sort of follows a bell curve. And so as you get too much antigen, you actually don't get added response. And plus, as we saw, there was a very clear shift in the IgGs, from the 1, 2, 3s to the 4, and the 4 is the down regulator with excess numbers of shots too quickly. And there's very good evidence that you're reducing your T cell functioning by doing that. And it was shown, because there were some good studies out of Cleveland Clinic and one in Quebec and others that showed that as people went and had more and more shots, they got less benefit. As a matter of fact, after 2 shots, almost half the people, in fact, half the people started to show negative effects. In other words, they were worse off. So, I think that's a bit of the answer.
Yeah. Speaking of negative effects, I was one of those people that did experience severe adverse reaction from the vaccine. Let's talk a little bit about what the side effects have been, any of the data you found contributing to that, and why you think it's been not talked about, and how it was almost phrased like the vaccine can not possibly do or cause any side effects or any medical conditions. That's just
right. So
it doesn't work like that.
Right. So I think that the one that was identified right away was myocarditis, and that's a fascinating subject, because it's a condition that's known by cardiologists. They know it well. It's not that common, but it can be very serious, and it's usually caused by some form of infection, bacteria or viral. So right after the virus was sweeping the world, there was a group that were looking to see whether the virus was leading to more myocarditis. And they did some very good studies. One of them was in Ann Arbor, Michigan, School of Public Health. The other one was in the Israeli military, and a few others. And they found really no increase at all in myocarditis from the virus. But as soon as the rollout happened, a year later, the medical industry started to see myocarditis, and it's easily explained. You've got the vaccine; it's got the lipid nanoparticle. It's causing, skating, and it goes right to the heart. The heart is making the spike protein and causing inflammation. And one theory that I subscribe to, the reason that it's more common in young people, more common in athletes, is because young people have a much better circulatory system. And so it skates quickly to the heart, whereas older people, there's a little bit of tissue edema and a little bit of, those tiny vessels that are blocked. So it takes a little longer. And by then, the product has diffused into, other areas. So you don't get as much of the concentration. But for young people and athletes, mainly, goes right to the heart, and you have a big problem because it's affecting the electrical conduction system. And the worst thing that can be done is exercise. So there, the warnings were poor. They were there, but they were poor. And it should have been pulled. But it should definitely, for young people that really wanted it, they should have been told no exercise at all, go for a troponin test after 3 days. And if it's showing inflammation, then no exercise for a month, because it's deadly. I mean, you can run into very serious problems. I don't have to tell your foundation that, because you know it.
As a society,
Exactly.
right?
Yes.
Do you remember when the college athletes, you would hear about them dying, dropping from heart attacks? That was, it was happening so consistently. It was very scary to see and watch. I don't know if anyone else noticed that trend, but nobody was blaming the vaccine, but that's exactly when everyone was getting it. Could have been a possibility.
Yes, absolutely. And, that in combination with the studies I mentioned about not showing increases during, right after the virus. So, and the ability to understand what's going on, which science does, there's very strong likelihood that it's a vaccine-related, mRNA vaccine-related problem, and serious. And I think it was not communicated forcefully enough, and that was a failing, and
Was it communicated at all?
Well, there was a little bit put on websites that there was a side effect of myocarditis, but not nearly adequate given the severity and given what should have happened, which is it should have been immediately pulled. I mean, it should have been pulled a long time before that, but should have been pulled right off the bat for everybody, but certainly for anybody younger, because they didn't require the vaccine. It really didn't have any urgency for them. And the risks with myocarditis, and we haven't even got to the other problems, but myocarditis, the risks did not warrant it at all.
Do you think you could explain to me why, yet again, why it possibly affected younger people more, why we maybe did not need the vaccine? And then also, if young, healthy adults and children were susceptible more to these adverse effects, what about pregnant women? Have you written about that?
Right. So in terms of the myocarditis for young people, the theory that I subscribe to is that they have really good circulatory systems, and so efficient. And so after you inject your vaccine, and it's because of the skating, it's moving around, the circulatory system is going to take it quickly to the heart. Whereas older people, their circulatory system is not quite as robust. And so by the time it gets to the heart, and it does, it's just in smaller amounts. That's sort of the theory that I subscribe to. In terms of why younger people were not affected as much by COVID, that I subscribe to the theory. This is, a theory, that is that the younger people are out and about more, and they're getting exposed to coronaviruses, not exactly this one, but similar. And they have a really, really good mucosal Peyer's patch intestinal system of making IgA antibodies and T cells. And as we know, they're made in the gut and they go up to the mucosal. So they're getting a little bit of, and when COVID hits, they're getting a little bit at the front end. So the bottom line is, because of how their intestine, their Peyer's patch is working better, they have a little more immunity in the nose and throat. And so the virus doesn't take hold as much there. And then when it gets to the lungs, it's not quite in as much of a concentration. And they're not as affected by the COVID side effect of red blood cell clumping. That's they're affected by it, but not as much as an old person. And where the younger people have a problem, and they certainly had it with Spanish flu, is the compensatory response in the lungs. But because there's less getting there, their response is not quite as strong. Whereas older people, they're not out and about as much. They don't have quite as good Peyer's patch going on. So more of it is growing in the nose and throat. And by the time it gets to the lungs, it's more of it. And they're really susceptible to the spike protein effects of the problem with clumping of red blood cells and falling blood oxygen levels. And their pneumonia response is in the lungs. Their compensatory response is significant too. Not as much as old people, but it's more because, it's more in old people because the concentration is got there and there's more of it. So they were more susceptible to it. Whereas Spanish flu, little different. Most people will say, well, I've had 3 colds this year and 4 last year, but I haven't had a bad flu in quite a while. So, what that's telling you is that there's a little less of the influenza flu going around than the typical coronavirus. So the young person with the added ability of the Peyer's patch wasn't quite as useful, because with the Spanish flu, it didn't have enough of a chance to make what was needed, the IgA antibodies and T cells, et cetera, up in the mucosal. So in that case, more of it accumulated in young people, and then it gets to the lungs, and now you have a real problem, because they have a big compensatory response. And that's what really caused some of the problems with the fluid buildup and et cetera, et cetera. Whereas older people, they didn't, they're not out about as much. And so the factor of the intestine is not quite as high, that sort of input. And they have just a thread more of memory T cell. And that way, they sort of remember, oh yeah, I had that flu 25 years ago. And so they had a little more protection early on. So what gets to the lungs in older people with Spanish flu? First of all, it didn't have the same problem with red blood cell clumping, and et cetera, as I understand it. And their compensatory response is not as robust in the lungs. So as a result, they tended to survive the Spanish flu. Anyways, that's theory, and others will have their theories. And as we work through this and learn more, someone is going to win a lot of Nobel Prizes. I should say many people will win a lot of Nobel Prizes as we start to understand. And this is one of the good things about COVID, if there can be a good thing, because it was mainly a very negative experience. But there's a lot of things that we're learning. The long COVID, we have a pretty good sense that it's not too dissimilar to chronic fatigue. And now we have a sense that maybe it's just people that are having more difficulty clearing the antigen, and maybe the T cell functioning isn't as good. And so in that sense, the last thing you want to do is give anybody in that category excess vaccine, because you're just causing problems. So we're learning a lot more to learn. And I think I answered some of that, but if I missed any of it, you can let me know.
No worries. You gave a very comprehensive answer. Moving on from young people to pregnant women and mothers, what did you uncover with the mRNA vaccines affecting them?
Right. So that was, a very unfortunate part of an unfortunate story, because normally, I say normally, but almost in all cases, the medical industry is very careful with pregnant women. We do not subject them to anything quickly. So there was absolutely no reason to recommend it to pregnant women. First of all, they're not in the age group to cause problems. And it was worse than that. I mean, it was said it was safe and effective. Well, first of all, there was nobody in the 80,000 initial trial who was pregnant. And secondly, there was one study done that I'm aware of that did involve pregnant women, but it was late stage and it was small. So, bottom line, there was inadequate data to support the statement that it was safe and effective. And even if there had been evidence that it was safe, it still was inappropriate, because far too early. It needs a lot more research before you're going to give this, because pregnant women definitely have a higher sensitivity. And we saw, the outcomes were that when you look at the studies done in Israel and other places, virtually every side effect that you can have from pregnancy was increased because of the vaccine.
That is very unfortunate, and I do hope that the women that did receive the vaccine then are doing all right, and their child is as well. Can you talk about some of the data analytics you did on excess deaths, and anything you found there to be interesting?
Right. So, I'm of the mindset or the theory that says that when you have a virus like that is targeting seniors with pre-existing, then you might expect deaths in that category to be slightly higher in the first year, but then you would expect deaths in subsequent years to be lower. And so, unfortunately, the excess deaths data for 4.5 years, starting in 2021, show that in all Western countries, it's higher by 10 to 15% on average. And in the two countries that had got the most mRNA shots, it's 20 to 25%, and those are South Korea and Japan. And we're also finding that in countries such as Russia and the former Soviet bloc countries, Romania, etc., they're much closer to what you would have expected, which is excess deaths lower than the calculated. So excess deaths is a big red flag, and you circle it around, the other findings that we're seeing, and it ties in, unfortunately, in a negative way.
Yes. Speaking of other countries, how do you believe this played out in the African continent? And what about Sweden? I believe you mentioned those in your book, correct?
Right. Yeah. So Africa, initially, there was some thinking that we were shortchanging Africa in terms of mRNA shots. But quickly it became clear that Africa was showing better results, showing less infections, less serious infections, less deaths, and a number of factors that could be contributing to that. First of all, it did have a low uptake of mRNA. It had a low uptake of vaccines generally for that, for COVID. It is a slightly younger population, more vitamin D exposure by sun. But in addition, their population is taking and has taken, they're very familiar with hydroxychloroquine and ivermectin. They take them for other conditions, malaria and river blindness, etc. So first of all, they were aware that these two drugs were thought to be helpful, so it would have been very easy for them to get it. They were taking it anyways, familiar with it. They probably still had some on hand. So all those factors really added up to better results for virtually all the African countries. Sweden, they were a country that followed the Great Barrington Declaration a little more closely than other countries, and they kept schools for the most part open. They didn't have any deaths of any children. In fact, I'm not aware of any deaths or very few deaths of infants and children from COVID directly. I mean, I'm aware of some children who died with COVID, but very few. But certainly in Sweden, there were none. And they kept the economy going. They kept the people who were not at high risk into society. And they didn't focus on the elderly quite as well as they should have early on, but then they did better on that. So their metrics are better than other Western countries.
All right. And then did you mention Sweden in your last response?
Yes. And, basically what I said about Sweden was that they followed the Great Barrington Declaration more closely. In other words, they targeted, they kept the society more open. They kept the schools open. They didn't find any deaths in children in schools. And they weren't perfect with how they targeted this initially, but then they did better. So they were closer to what I would say is a smart response. And they had better results than other Western countries.
Thank you for repeating that. That was, now, as we're getting close to the end of this interview, do you think you could tell me why you believe some people were affected more than others by COVID, the virus?
Right. So I think that genetics, younger people, I think we said generally they have better payers patch systems. They're making the et cetera. But within the same age group, it's a bit of genetics. It's a bit of luck, because if you're exposed to a little bit of the virus early, then the very efficient young payers patch is giving you protection right off the bat. It's just luck of the draw. And the other piece is that some people have better functioning payers patch than others. Those are some of the reasons why I think people within the same age group, even house, would have been more or less affected by this particular COVID-19.
Do you have any thoughts on the pharmaceutical industry, and what about alternatives?
Okay, so pharmaceutical industry, in my opinion, works in an imperfect environment. Some of it is their own making, but a lot of it isn't. I think they could really benefit by a change in some of their parameters in terms of how they're set up, how they work. They would be just as profitable, if not more. So there's some things that would help them, some things that I think probably make it a little harder for them. But by and large, they are working in an environment that is not perfect, in my opinion. Secondly, vaccines in general, I would say we shouldn't be afraid to review what we're doing. I'm a vaccine person, but doesn't mean that we can't look at the data and say maybe we are giving far too many vaccines to young babies and children. Maybe we're giving them things that they don't need for years. Maybe we're giving too many. Maybe the spacing is wrong. Maybe there's contaminants. Maybe we need to unbundle. Maybe the bundling is an issue. So there's a lot about the vaccines, even the ones that are the most successful, I think that we could review and not be afraid to review it. And the other one is generally on the mRNA. One day it may be the best technology ever, but at the moment it didn't pass. And it had too many side effects. The technology itself not working the way it's supposed to. It's causing problems. Should have been pulled. And we need tougher monitoring and tougher neutral people. I mean, we almost had it early in the pandemic, but not quite enough. We had a few brave doctors who tried to communicate directly with high ups, and that was helpful. But you need that neutral group. In addition, you do need your regulators, and they are going to have to, you can't just say, well, you can't work here for 5 years, because you want continuity. You want people that really understand what's going on current. So it's really education. You're now wearing this hat. You're not wearing that hat anymore. And I suppose enforcement, but also, as I say, if you have a neutral group, in addition, that doesn't have any crossover, then in that case, it's like a hockey team. You have your different positions. So a hockey team, you got your stay-at-home defenseman while Bobby Orr is up there scoring, and you got your back checker. So you need different people. So you need that group that's neutral and that can add to the mix. And in this case, it was low-hanging fruit. I mean, they had so many red flags, they wouldn't have known which one to go with. I'm laughing, I shouldn't, because it's a very serious problem. But, in the end, the heroes are the doctors and they're the nurses. And I'm not as hard on the drug industry, because they're trying to make product and they're subject to bias and staying with things too long. This one, they definitely did that, which is improper, but it should be caught. This one should have been caught by regulators. It should have been caught by a neutral group. So really, everybody seemed to have failed, except for some brave people that, stood up and tried to be countered.
Very well said. I have one final question for you. In regards to your book, the title of it, do you think you could explain that to me?
Right. So success. So it's COVID-19 success or red card. So I tried to make it a title where people wouldn't know the content at the beginning. So they know it's COVID-19. They know it could be a success, or they know it could be red card. And red card is, as I'm sure you know from soccer, you get a red card, that means you're thrown out of the game. So, and I start off being complimentary, a lot of good things being done, but then we get into this exercise, and the data, the evidence, the procedure, the method, the monitoring, I mean, it needs improvement. I mean, a lot of problems, and my book tries to explain it as best I can, from beginning all the way to the end. And there's topics that we haven't had a chance to talk about clearly, but I do cover it in the book. And the book is intended to stimulate discussion and debate, and other people will have their own views and opinions. And as you mentioned earlier, we didn't really, or society didn't really pivot on the fly properly. So this is why now there has to be a painful assessment, and we shouldn't be afraid to do it. And it's not that we're, being hard on anybody or the medical people, but everybody has to get better, and that's the only way you get better is by being critical. As a friend of mine said, medicine does not have a lot of room for error. So you have to be monitoring everything, and you have to get better all the time.
Very well said. It has been a pleasure talking to you and interviewing you about your upcoming book that was released today. Is that right?
Yes, it's available on Amazon as of today. COVID-19 Success or Red Card. And I hope that people will buy it, and I hope they'll enjoy it, to the extent that a serious and difficult subject can be enjoyed. But I hope they'll find it informative and helpful in terms of their thinking about the subject.
Well, I'm sure it will stimulate some thought and hopefully some conversation and debate about this topic. It needs to be talked about. Thank you so much for coming on Focal Point, Mr. Langstaff, and I look forward to reading your book myself.
Well, thank you very much, Professor, and I look forward to keeping in touch. And thank you for the opportunity, and good luck with what you're doing. And I hope that your adverse events improve. And also, please pass on a very warm, good wishes to other members of your foundation, including, of course, Dr. McCullough, but others as well.
Absolutely. Thank you very much.
Thank you.